Okay. Good afternoon, everybody. Ladies and gentlemen, dear colleagues, dear friends. It's great to see you all still very energized and ready for the final plenary. My name is Tolib Mirzoev. I work for the University of Leeds, and I've been tasked with immense responsibility to introduce this final plenary. To start with, I would like to start with the result of the poll that has been going on for 24 hours, and thank you very much for everybody who voted. So the question we asked through Twitter to form the word cloud was, when we talk about health systems that leave no one behind, which driver of social exclusion remains the most invisible? And these are the answers that we have got that our communications team has helpfully pulled together in the form of the word cloud. I'm not going to summarize all of that, but that gives a nice platform to start thinking and frame the session within the context of drivers that the colleagues in the audience see as being the key to be addressed. As we all know, that further to provision of essential health care, health systems form the backbone of social protection for all population groups, and it's been a significant and central feature of both Alma-Ata and NHS that featured quite explicitly throughout the previous plenaries. However, we also know that many groups are still being excluded and discriminated. So these include the whole range of constituencies, such as those affected by conflicts and crises and emergencies, migrants, and those who are affected and discriminated because of their gender, because of their ethnicity, religion, sexual orientation, or some of the other identities. So this plenary takes this background and sort of aims to explore how the health systems can contribute towards social justice and social inclusion, showcasing and sharing some of the excellent experiences of our distinguished panelists to address, to effectively identify and address the needs of most marginalized populations. So this is promising to be a really good discussion, and I'm sure you all are here for the treat. And of course, we save the best for the last. So without any further ado, I would like to introduce the moderator of this excellent panel, who will then introduce, in turn, all the distinguished panelists. So this panel will be led by Professor Sabina Rashid. Professor Rashid is the Dean and Professor at Brock James P. Grant School of Public Health at the Brock University. Her qualitative and ethnographic research focuses on gender, reproductive and sexual health, sexuality, and the emotional well-being of adolescents, women, men, and marginalized populations. So very well suited to this plenary. Sabina is interested in how structural and social inequalities create greater vulnerability for the poorest and impact on their ability to realize their fundamental rights, human rights, fundamental health and human rights. And Professor Rashid has been involved in research for over 20 years, ranging from research at the grassroots level and actively engaging in research uptake at the national level. So with this background, Sabina, it's over to you, and please give a round of applause to the Professor Rashid.
Thank you. I don't know if it's on. Is it on? Can you hear me? So we've been given the hardest task, bringing you all together at the end of the day and keeping it very energized. But I promise you, because we have a very exciting panel, that I'm privileged to moderate. So let me introduce you to Sana. Sana is a public health researcher who works at the Center for Health and Social Justice in Delhi. She's also an alumni of the Emerging Voices program. So round of applause for Sana. We have Fouad, Fouad, who's Syrian, an assistant professor of public health practice at the Department of Epidemiology and Population Health and a co-director of the Refugees Health Program at the Global Health Institute at the American University of Beirut. Welcome. We're very excited to have you.
Thank you.
They have much longer bios, but I'm keeping it very short because I've been warned in about 55 minutes we will be removed from the stage. So I have to be the timekeeper. We have Dr. Simukai Chigudu, who's an associate professor at of African politics at the Oxford Department of International Development, Oxford University. He has a book coming out, The Political Life of an Epidemic Cholera, so please buy it. It's very good. And we have Taher Qassim, who's born in Yemen, but has worked for 34 years in Yemen, Sweden, and England. And he's mainly worked with communities and primary health care, public health, and a lot of his work has taken him to the Middle East and Africa. So welcome. So, given all your experiences, I'm going to ask you some very, very specific questions, and then you can share with the audience. And then, depending on how we go with time, maybe we'll open it up for a few questions, okay? So, from your own experiences, and anyone can go, there's no order here, can you tell us a little bit more about how health systems can be aware of the needs of the most marginalized? Any key reflections?
Yeah, I will.
Okay.
Yeah, you? Go ahead. Go ahead.
Okay, thank you very much. It really is a tremendous pleasure to be here. So I feel a bit of an interloper as somebody who's not a public health researcher or professional as such, and my work very much lies within the realm of politics. To that end, the book that Sabina mentioned that I've been working on is about the politics of a catastrophic cholera outbreak that occurred in Zimbabwe over 2008 and 2009. Now, during this outbreak, the disease erupted in the high-density townships that sort of circumnavigate Harare's metropolitan area. The disease then rapidly spread to peri-urban and rural areas before crossing the country's borders into South Africa, Botswana, Zambia, and Mozambique. Over a 10-month period, cholera infected nearly 100,000 people and claimed over 4,000 lives in the process, thereby making it the most extensive cholera outbreak in modern African history, and also unusual for being associated with neither environmental catastrophe or open conflict. And so the question becomes, how could an otherwise simple disease that is easy to treat and difficult to spread become such a massive calamity? Now, at the time of the outbreak, there were a number of polemical answers to this question. On one hand, a fierce international community condemned the Zimbabwean government of having neglected its public health duties to its population and declared that the government was proven illegitimate and needed to be replaced. On the other hand, people like the now late Minister of Information at the time said that cholera was racist, terrorist, biological warfare used by the British to undermine Zimbabwean sovereignty. So as a scholar, my drive was to try to move past that and understand both what happened in an empirical sense and then try to understand the ways in which it was politicized. In speaking to a senior figure within the Ministry of Health, I put these questions to her, and I think she captured the problems obtaining in Zimbabwe quite succinctly. She said, when you look at cholera, it is not a health systems issue. It only occurs when people eat shit. And she was being quite literal in this sense, that the cholera outbreak, that is to say, the broad social conditions of its emergence, how it interacted with food insecurity and malnutrition, as well as a catastrophic water crisis, meant that people were reduced to eating polluted and contaminated water and were unable to claim their rights because of the violence that had marked the political violence that had marked the year 2008 and the wider economic crisis in the country at the time.
So you know, you're talking about these structural and social factors that are critical. And I just wanted to hear from maybe Taher or Fouad about, in your context, when we talk about health systems and marginalized populations, is there any sort of similarities or what your thoughts are about?
I think the issue of how we define the most marginalized people. I mean, I think it's become broader and broader now when you think about the marginalized people. Mm-hmm. Describing the current conflict conditions, we can easily distinguish that this is very protracted now. We're talking about now the average length of displaced population is 37 years, jumping from 19 just in 2000. So it's very long, it's protracted. Second, it's sort of people move into urban settlement more than camps. Now, 85% of movement of those, moved are living in non-camps. Yeah. Third, it's unsolved conflict. Look to what happened in Afghanistan, Yemen, Iraq, Syria, Libya. And the list is long about, 20, 30 years of unsolved conflict. And actually, the last issue, not least actually, is the issue of chronicity. Yeah. So we have outbreak, but also we have problem of chronic conditions, including chronic diseases. So people move, and then they stuck in sort of a non-system, non-clear system, and they have their chronic problems, that's not solved. And this is the new model, the new problem that we need to address, that we need to take about that. Outbreaks are something, of course, important, but what about the long term? What about the problem that created by the long-term movement?
Yeah. So I was going to, Taher, because there's a cholera outbreak in Yemen. And did you want to speak to some of that in terms of marginalized groups and health systems?
Yeah, I will start about the health system. I work here for the Department of Public Health local authority in Liverpool. We have a robust planning and needs assessment. Everything is there. This doesn't mean that everything is perfect. There are also groups that are left behind, and it is up to public health to find who they are, where they are, and what kind of health system they get or not
so
get.
Which groups are left behind? Can you share a little bit more specific?
There are some. I have worked many years among the black and minority ethnic groups, where we looked at health, we looked at education, we looked at are they taking the health services as it should be, because it's all there or not. So this is one side. But what I want to reflect to what Simukai has said about cholera in Yemen. I don't know if there are generals here among the public, because I think generals are military who are responsible for the war, and sometimes...
Any generals who want to reveal themselves?
Here,
it's okay, we won't harm you.
Because
I don't think there are any generals.
They're
not, they're hiding. They prefer to be anonymous for today. They want to be anonymous today.
It's good for us.
Okay.
It's good for us, so we can speak freely. I think the reason being is that cholera in Yemen is not a natural cholera. It is a man-made cholera made by the destruction of all the system that was already there. I was one of the people who started the primary care in the early 1980s. Now, that system collapsed. The water system is collapsed. The sewage system is collapsed. And we end up picking up the pieces of more than 1 million people that have been affected by cholera. And I don't know how many died. And still in its 4th year, that system collapsed completely. And we are, or the health is picking the system. I really don't know how it's going to be. But just to give you a comparison, I work in here, my body in here, my thinking in here, but also the whole of the thinking is about what is happening in Yemen. It's not left. It doesn't leave me.
Thank you. So Sana, because I know you work gender and intersectionality, and I was wondering if you could speak to some of these issues, because there must have been some communities, Simukai, that were more affected than others. And from the perspective of working in India, but also if anyone could talk a little about, because communities are kind of homogenized, but it's really quite,
So I want to go back to this question of which are the most invisible groups among the socially excluded. And I think gender is what it said, and most people seem to think that gender is the most excluded. And both Simukai and Fouad and Dr. Taher have spoken about some of the structural problems that cause inequalities. And if you think about gender, it's actually really common for us to look at gender disaggregation in our data and understand gender inequalities. And so if you say that gender is the most socially excluded thing, that there's something there. And I think what we are stuck with is that we are looking at inequities in terms of who's left behind, and we are still trying to identify who the populations are. We are doing some amount of a good job of describing what that inequity is leading to, but we still don't have a grasp onto what's the process that's causing the inequality or the inequity. And
can you break down, like when you say gender,
yeah,
how you're defining that? Can you unpack that in your work or
right?
Yours? Because
so, for instance, if I talk about access to family planning, there's a recognition that there's a lack of access to family planning. But when you introduce a family planning program, the only thing that you think about is access and about who's getting the contraception and who's not, and you don't have a sense of history about where family planning programs came from, the fact that they had a eugenic history, the fact that there's targets, the fact that there's coercion, the fact that there's poor quality of care. The program that you implement can end up increasing access, but it could be of poor quality, it could be coercive, and I think the processes that caused the problem in the first place then don't get addressed. The gender dynamics that cause this problem of lack of control of fertility don't get addressed. And I think that's a lot of what's happening in equity discourse at this point. And I feel like in the next 5 years, we'll be at this point, in the same conference or another one, talking about how equity got diluted and how it became about targets and how it became utilitarian. And we are doing that, we are doing that about UHC 2030, we are doing that with what is health system strengthening, and we shouldn't be doing that in the next 5 years. And if we want to do that, then we have to think about structural issues. We have to think about where what happened. You had a functioning health system. And if you don't address that, then you're stuck with something like this.
I want to push this a little bit, and you're talking about, so there's the politics of inclusion, exclusion, but are there certain groups that we're not talking about? Yeah. We're talking very obviously about women here or adolescents, but what about, yeah.
Can I challenge this question?
Oh my God, Fouad.
Always.
You've been challenging me all afternoon.
Going to check who are those left behind. I mean, maybe, in this conference, those who are left behind are, I don't know, ethnicity group or gender or, And next conference will be, another group that we will check about how that. Why we're thinking about, the system that need to address that left behind and how to define this left. How we can think about system that always being inclusive. The issue of structure, the system that shouldn't be something about this definition of left behind. We need to think about always a system that's dynamic enough to be able to include,
So I agree with you, absolutely. But the reality is, if I wanted to hear about groups or individuals you're talking about in your context, are there certain groups or individual communities, I work a lot in informal slum settlements, and we talk a lot about women, and of course they're very vulnerable. But no one's talking about young men. And there's a huge problem. So I'm just, there's other groups. I'd like to Simukai.
Sure.
Yeah.
That's, of course, a very pertinent question. To use the example from my own work, many of the people whom I spoke to and interviewed were residents of these high-density townships in Harare, much like the slums that you described. And when I spoke to people there, what they said about what they remember of the cholera outbreak was that not only were their friends, neighbors, lovers dying because of human waste, but they felt that they as a community were waste themselves. So much like human waste is expelled and eliminated from the physical and individual body, my interlocutors felt that they were being eliminated from the social body. And as I pursued that line of questioning further, they spoke in poignant terms about how they felt.
Who's they?
So these are the urban residents that I'm talking about in township areas. So I want to come to that in a moment because I want to try sort of characterize some of the collective sentiment, and in part because many of them are opposition voters and so forth. They had come to experience the Zimbabwean state, the Zimbabwean government, as a sinister institution, one that is capable of punishing portions of its citizenry when they express or pursue kind of political lines that go against its prevailing power. But then when I try to disaggregate that even further, of course, the experiences of people within these communities was highly differentiated. So there were the structural factors, but of course, women were affected in quite distinct ways, many of whom were resorting to various kinds of informal trade, including sex work, to keep their families afloat. In certain instances, it was young men who were not target groups for hygiene initiatives, and so forth. So there's an element of contingency within these dynamics, in as much as there are structural ways in which communities become excluded. And so I guess the takeaway for me is, on one hand, having the reflex of thinking about what are the ways in which structures tend to reproduce various kinds of social cleavages, and then once we've identified, going further into those communities and seeing how those specific dynamics play out.
Okay. That's I mean, I know you've been talking about these mobile populations and migrants, and
I have to agree with that. And I think this question of what about the men, I know it's a provocative question to get me to respond, but I think what it does again is pit that we're talking about the women, but are we talking about men enough? But if you examine the processes behind what's happening in informal slum settlements, or what's happening here, maybe that is rooted somewhere in gender, but there are a host of other processes that are playing out. Sure. And if you don't examine that enough, then it appears, and the conversation on equity tends to be like this, like almost as if there's a limited pie, and we're all vying for that without challenging why is the pie so small. And you know, we talk about extreme poverty, and there was a meme when the SDG conversation was going on that maybe one of the goals should be end extreme wealth, and you know, not end extreme poverty. And so this question of pitting groups against one another as if one wants to be more equal than the other.
And many things.
Yeah, and I've heard conversations around cost effectiveness even in this very progressive conference, one of the more progressive conferences in health. And perhaps we should be challenging some of these things because it's a question of social justice. And so whether it's poor men, whether it's lower caste, what are the processes that are causing the inequality? I think that's got to be the focus, not who is left behind.
So I was just going to move a little bit, and then we're going to ask a couple of questions from, of course, the very wide awake and extremely engaged audience, right? Who's been listening, hanging on every word that our panelists have been saying. And we promise we're not going to give a quiz. We're just going to ask you to ask a few questions. But I wanted to say, this is the larger picture. Okay, some of it's depressing, but some of it, we also have some hope. We're in this field, we're working, we believe, we're also inspired. So I want to ask you very quickly just to share, are there any effective or some effective strategies or some innovation or approaches that you've either been involved in or heard about or worked in through your 34 years of experience or 20 years in your research in your areas that you could just share? Because I think there are opportunities and there's lots of also good work that's going on despite the structural challenges, despite the social inequalities. So I'm going to start with you, Fouad.
It's good to look for positive or successful story or nice stories. I mean, I think it's not just about encouraging, us to, but also to think about the different mechanisms that. One example is the issue of migrant health workers. The example that Syrian health workers, when moved, they couldn't get like a work permit, in the neighboring countries, except in Turkey. So, and interesting to see by time because those were like a considerable number, and hosted in in a country that already has some health system problem. They were able to do what's called now informal health system. On one side, it's bad to have parallel health system, in one setting. So, like the national health system and the UN agencies' health system, informal health system. But on the other side, actually, it's quite interesting how people can adapt and produce in a good willing, something to, exactly, and to offer services. This sort of, adapting mechanism can give us sort of hope, how we can manage in some, very dirty conditions.
Taher, something from Liverpool or Yemen?
I will bring two.
Okay.
You
can bring three.
Yeah.
I can
4 for you, Sana. Okay.
Back for me, 4.
When I finished my master's degree at the School of Tropical Medicine, and then I was among the Yemeni community here, and I thought, they are progressive, educated, and they do everything. And I was struck, that was not the case at all. So we started to do a Yemeni health profile, because that's, again, I do not have time to talk about groups in behind. They were invisible, as if they moved from one village to another village in the middle of Liverpool. So I worked with a small group of people, to see where they are, how many they are. Are they 5,000, 10,000, 200, 100? So the first advice was to say, don't go and tell the Yemenis in here in Liverpool that you are going to do this study, otherwise they will say you are spying on them, or you are taking their names to the local authorities so they will pay tax. So, okay, we spend a lot of time to do some work in hidden roofs. We did that work. And the good thing, as a result of that, then the Yemeni community themselves started to see, wow, this is about us, and they want to talk about themselves among the different public sector bodies. In Yemen, when we started primary care, I used to go to very rural areas. They have not seen anybody there at all. And part of the condition was that if you start primary care training, there should be, again, about women, should be men and women together. So no area will bring only a man and no woman. So it was conditional. And that was problematic, but that was the condition. We made it, and that was very fantastic. We managed to bring a man and woman to the training, and then they went back to their own villages to do primary care, and that was a good story.
Wow.
Not today.
Yeah, I think these are great examples, and to me, this project of leaving no one behind assumes that those who are left behind or who we need to take forward or whatever agree with the terms on which it's going to happen. And those terms need to be defined, and they need to be, it's almost cliche to say it needs to be context specific. But I think these are examples of how that can be done. And community participation, which has been around since Alma Ata or before, again, a very, very diluted, misused, reductionist approach to it has been to use communities in a utilitarian ways to get them.
So what would be any kind of...
so a more, when you talk about community participation, how do you center stage community concerns and communities' ideas of, and who in the community are we talking about? Sure. Who are the people who are going to make decisions about their own lives? And I think we need to revitalize that concept in a more political way, given how it's played out over the last 40 years since Alma Ata.
Thank you.
So in my field, I think that African bureaucracies often get a bad rep, typically seen as sclerotic, slow-moving, and not well adapted to difficult circumstances. And yet my research showed that in some ways the opposite can also be true. I was struck and moved by the degree of civic commitment and imagination with which many of the people who were working during Zimbabwe's cholera outbreak negotiated what were extremely difficult circumstances. Very often, people I was speaking to, say, for instance, in the Ministry of Health, would talk about, okay, we ignore the political rhetoric and polemics, and we pull strategic levers with various kinds of partners and agencies to mobilize a response. And I think that one of the lessons I took away from this is that actually much of the technical expertise exists on the ground, but that technical expertise is coupled with a subtle reading of the political sense of what is possible and what is not. And many of my informants kind of spoke about how what they really needed was to be essentially capacitated, to have a bit of faith from their international partners that despite apparent appearances of the government's posturing, there were in fact ways in which working through these bureaucracies much good could be done. And so in this sense, I would emphasize a sort of optimistic message that a careful and intricate reading of the context and the politics as they are at play can mean that there is much greater scope to work within a system that appears at face value as completely broken.
It's really important, Ed, to get these narratives out. Often the dominant narrative sort of prevails. I'm going to open it up, being mindful of this big clock that's ticking away. Maybe 4 or 5 questions from the community that stayed behind to be with us. You guys are special. Tell everyone else who left. Send them emails. They really missed the best panel. So do we have any questions? Okay, we have a question here. Another question here. Just 2? Any back there? 3? And is that someone with the 4? Yeah. Okay. Can we get you to, can someone help us with the, is there a microphone? I don't know.
Yeah, that's microphone.
Oh, okay. Could you please come up and introduce yourself and ask you? We'll take all the questions together and then I'll leave it to the panelists. Thank you.
Hi, it's Lucy Gilson from the University of Cape Town. It's not really a question, it's an addition to what Simukai just said. I think that we regard bureaucracies as dysfunctional and we ignore the people in those bureaucracies who are every day trying to make a difference. And I think the issue is how we sort of release the energy of those people or how we engage with those people. And they are folks who also engage with communities and with those around them. And we get bogged down in the structure and ignore the people at our peril. Yeah. Thanks.
Thank you. Questions?
Thank you very much to the panel. My name is Eckhard Kleiner, working for the Human Resources for Health 2030 project. And I would like to suggest that there is another marginalized group, and those are the community-based or the community health workers that actually often care for those that are marginalized. And there was an opportunity at this conference actually in one of the plenary sessions to address this question. I'm not sure I heard a lot of new ideas there in going forward. A lot of it sounded like what we have been struggling with for the last 40 years. Would this panel care to address that question? Because community health workers are still often a stopgap measure, and are we continuing another 40 years along those lines? Thanks very much.
That's a tough audience.
Hi, so my name is Miata, and I'm from the Ministry of Health in Liberia. I thought I would add 2 points to the conversation. The first thing is that I think by and large, our various health systems need to firstly recognize that there are marginalized groups within the system. We need to acknowledge it, because if you don't acknowledge it as a starting point, I'm not too sure how our various health systems are going to deal with it. My second point is in terms of access. 40 years on in Amata, right? A lot of countries, we are now talking about USC and SDG and what have you. We will soon start to turn SDG around. And years after, we will be talking about access, but usually when the issue of access is mentioned, we take a geographical kind of dimension. And I think it's important to recognize that even within the urban-rural divide, there's also rural in urban. A lot of population is moving towards the city, which is causing a bit of crowdedness, and we need to recognize that and not just talk about who have access to services, because you can leave a lot of population behind if you don't recognize that. The disabled population, our health systems in many instances is not very sensitive to people who are disabled. We tailor the service on the backdrop that everyone is able to walk, everyone is able to see, and everyone is able to talk. So
Miata, they're very good, but they're going to kill me because I'm timekeeper. Did you want to add anything else? other than the people with disabilities. Thank you.
Hi everyone, it's Suyan Liang from Peking University. I have one question about community health worker. So I've seen many research about this in the African country or the family health strategy in Brazil. So I'm wondering whether this program will work in the context like in developed countries like the United States or something else, because I've seen so many research about the community are done in the African countries, but I'm not sure will that only work in the African countries or in the less developed countries? Thank you.
Any other? Okay, yeah, please go.
I would like just to share a take-home message from this panel already, is that there are other lines of marginalization that are poorly addressed in our own researches, like political exclusions, like groups of, or ethnic groups that within a country because of political reasons are excluded from programs and are poorly included. So the lines of exclusions can be a lot, so we have to be aware about those underexplored lines of exclusion that can be found in two countries.
Thank you.
Hello, everyone. I'm Renzo Ginto from the Philippines and Harvard University. I would just like to add a contribution. And we've been talking a lot about social exclusion, the marginalized, leaving no one behind in this era of SDGs. But it's just really frustrating that for the past 5 days, we have been discussing about health systems as if they're totally detached from the climate reality that is the backdrop of all of these forms of exclusion and vulnerability in the 21st century. There's only one session whose abstract mentioned the term climate change, and it's only Professor Costello at the start of this conference who also mentioned it in the plenary. I think it should be a wake-up call when during the Health Systems Research Conference of 2018, the UN also comes up with a report that says that 1.5 degrees Celsius temperature increase is becoming less likely to be attainable. We should be starting to think about future health systems that can withstand global temperatures along many other planetary health challenges that will exacerbate health and social inequalities and will drain our resources, the resources of our health systems worldwide.
Okay,
Thanks.
thank you. Thank you. So maybe you'll be on the next panel in Dubai. Instead of going around, can one of you, whoever has the answer to community health workers, and how do we kind of move that forward, who wants to have a go at that?
Can I, so there's 2 points I want to make. One is that community health workers, as we all know, are largely women, most often poor. And they bear the burden, at least in my country, of a lot of
You can't, I don't know if it's your microphone.
Oh, sorry about that.
Oh, you remove it.
She just didn't want to answer recorded.
The point I want to make...
I can just hold it.
Maybe just hold it up, yeah.
The point I want to make about the community health workers is that a lot of the conversation around community health workers is not addressing structural problems of how they've come to be so disenfranchised. And I think it's a larger question of informalization of labor in the health system workforce. And there's reasons for why that has happened. And there are, in my own country, there's unionization of community health workers. They're asking for regularization. They're asking to be treated as equal employees. And I think if we don't address the causes of why that has happened, and it's going to be more and more health system employees who are going to become contractual labor, if not completely informalized. And so I think we should take that conversation of community health workers beyond just that of the community health worker to asking why we are living in a health system or why we are making use of a health system that cannot provide labor rights. And then we are talking about private sector engagement and all of that. And all of it has implications for the regularization of the health or the irregularization of the health workforce. So again, I'm going to talk about processes and looking upstream. My second point,
I'm going to come back because we're going to do final statements. Sorry. So Fouad, you wanted to quickly add, and then we can do sort of a...
Actually, I don't know if it is to add to what Sam mentioned. I think the issue from the questions, but also from the discussion, that we never mentioned that clearly is the political, factors or determinants when thinking about political health system, but also when thinking about the causes. Yeah, climate change is an important issue, of course, and need to be, but climate change is not detached, separate from the political actually willing to solve such a sort of issue. Same with the community health workers, the issue of inclusion people. So the issue of politics, I think Simukai mentioned that, but this is really important to bring to the table that factor that actually influence a lot, many decisions about health systems.
So Taher, you had a question about in developed countries, community health workers, and you've been working in Liverpool, or anything else, any dimension you want to add to that?
I think from Liverpool, I wouldn't think that there are NHS staff and there is public health staff, well structured, it depends, if the policy, if there is cut, there is cut in staff as well. But I want to go back to the community health workers in Yemen, for example. As the war, because there are no generals in here, they destroyed the country, and because they destroyed the country, the people who were serving the people in health, they did not get their salary for the last 2 years. We are in the 4th year, and of course, even if they wanted to do their work in these circumstances, they are gone, they cannot survive, or they have to do their own business. And that's why the impact of war is enormous. One of the doctors that was treating cholera in one of the hospitals, she was overwhelmed, came back to Liverpool School of Tropical Medicine Health. She was an ex-graduate. I cannot cope with cholera anymore. They were all everywhere, and she did not have enough staff. And the School of Tropical Medicine, thank goodness, with Sally's leadership, support her. That is how there is the link. The link, when it was so critical, there was some kind of support.
Okay. So did you want to add to this, Simukai, or anything in addition to?
I guess I would maybe briefly comment on questions around thinking about political exclusion as a kind of salient category. And it would just be to make the point that, this kind of occasions more and more interdisciplinary thinking. Very often, our colleague mentioned ethnic groups that are marginalized, but ethnicity itself is not a primordial category. It's not something that exists outside of time and place in history. And in this sense, the expertise that can be mobilized from disciplines like politics, like history, like anthropology, the kinds of ways of thinking that really flesh out what we mean when we talk about context and how we come to understand how certain political identities are constructed, but also how contingent they are, gives us deeper insight into the machinations of power that exclude them.
So, that's a lot to take in. We're talking about very complex, very fluid spaces. We're talking about politics, what counts as how we understand, unpack health, how we understand what's evidence, what are the narratives that dominate, but also how do we understand these health systems and the actors within these health systems. And often what I'm hearing also is that poverty then becomes this socioeconomic variable alongside other variables, but really there's some underlying conditions. Earlier when we met, you were talking about water and housing and basic support along with health. And this is sort of some of the themes that have also come up across, the role of other sectors. So I was going to say, if you had to say, inspire, let's say. There's a lot that's not, it's complicated, and there's a lot of stuff, there's a lot of challenging times, but there's also a lot of, I would like to be a little bit more optimistic and move forward, and leave the audience with a few thoughts from all of you, given your experiences, something final about where you see, you know, where health systems or any ideas or some of your work or strategies or, yeah? I'll start with Sana.
2 points. One, when I'm listening to all of the comments about who's left behind and who are the marginalized groups we don't see, one of the things that jumps out at me is the fact that the definition of who is not excluded is really limiting. And it seems like very few of us are not left behind. There's a growing, you know, that there's different political processes happening that are excluding more and more people. And that says two things. One is that there's something needs to be done about that, but then it also points to the fact that we need to have more cross-movement alliances. If we are talking about the right to health, there are people talking about the right to food. There are people talking about communalism in my country. There are people talking about caste. And I think there's a lack of conversation between people talking about exclusion among different sectors, which is part of the siloizing. The second point that I want to make is this question of inclusivity and who is invited and who is not. And in this conference, I think one of the things that I've seen, and I've attended a few conferences before, is that there's definitely a greater diversity of gender, of women of color that I've seen. And I was in a session yesterday morning, I think, where somebody remarked that it's really good to see everyone presenting studies from their own country. These are studies that they've done themselves, and they're of their own country. But there's another dimension that I want to bring into that, and it is that even those of us from the South, women of color from the South, who find ourselves here, need to be examining what our sense of privilege is, because talking about equity isn't just talking about who's left behind, but who's driving up front. And I think it's important for us to examine the structures that prop us up, and myself included. Why am I here, and why is Sabu, who, you know, was not awarded a visa for having insufficient funds, not here? There are networks that prop me up. And I think unless we continue to keep examining those, this project of equity is not complete. And I'll just end there.
Very powerful.
Disability.
Okay.
Whether my work in Liverpool or in Yemen, I think the involvement of the people that you have in mind, or you think that they are not part of that health system. If you find them, get them involved. I've done it here when I was involved with the black and minority ethnic groups, done a lot of good work. I've done it in Yemen, where rural areas that were not part of the system at all, we involve them, they understand what it's all about, and they got involved. I think the key is to involve people as long as you want to involve them. Otherwise, they're marginalized, they're invisible, you don't know where they are. But if you want, they are there, you can involve them, and they can do something positive.
Okay.
You know, I think that the issue of people on the move is a major issue for me. When talking about, you know, the last 2 or 3 decades, we have refugees, internally displaced, stateless people, you know, unregistered, you know, displaced population, labor migrants, so long list of people that moving in quickly and moving in short time and moving massively. You know, we're talking about millions that move just in the last, you know, few decades. So the health system, we need now a new paradigm for health system that's able to integrate all those people, you know, under one inclusive system. Otherwise, we will face the issue of who's left behind and change by time. And today is, you know, such a group, you know, another group. So we need to have such a sort of new paradigm, thinking about health system beyond the border, maybe beyond this issue of, you know, national borders that, you know, allow people to come, and sometimes, you know, another barrier, people are not granted to be able to come in.
Are you pushing those kinds of discussions in your institution, in the center that you work, where you are getting them to critically reflect on these ideas of who's being excluded and included, or even I was going to say in the spaces you work in?
Certainly, certainly. This is an important issue to raise, where I work at the American University of Beirut, a sort of thinking about integrating health system. It's also part of our work at the Lancet Commission on Migration and Health that will be issued recently, maybe next month. So it's all that issues now on the table. I'm hoping that the next conference, health system will be considering that the health system beyond border.
Yeah, okay. And Simukai, you're going to be involved? Am I allowed to say that? Divine?
Yeah,
now?
sure.
Okay. So you can make sure it's on the table, right? Okay.
Sure.
Yeah.
So in many ways, writing this book on cholera was a thoroughly depressing affair because it involved uncovering a series of tragic circumstances in which so many people lost their lives and in which I saw some of the more sinister and uglier sides of politics. At the same time, there is some hope to be found in many of the unsung heroes I met, who are often excluded from the history books, but who nevertheless toil under difficult circumstances, engage in various kinds of community volunteer work, or at least continue to articulate a vision of what a more inclusive body politic might look like. And as I was writing, it kind of recalled to mind a passage from one of my favorite novels by the French writer Albert Camus, who says that he wrote this book to state quite simply what we learn in a time of pestilence, that there is much more to admire in humanity than to despise.
Thank you. So we still have a couple of minutes left. Does anyone want to make any comments or any questions? Oh, here we do. Great. Thank you.
Thanks very much for the panel, especially for the last rounds of discussion. My name is Christina Zarowski. I'm at the School of Public Health at the University of Montreal, and we live very close to Donald Trump land, who was elected by people who felt excluded. So I was really glad yesterday to hear universalism come back, or universality, and not just identity politics of who's more marginalized or who's more excluded. I also want to echo the comment around climate change. I've been sitting in the sessions here, and I'm an anthropologist, but with a really strong inner surgeon. I want to fix things. I want to do things practically and close to the ground, but our world is literally burning. How do we address that? It seems to me that the big challenges facing the health system and the health sector are all outside. So maybe it's time to start listening to other fields, other disciplines, other sectors, not talking about health systems, but talking about their own systems or their own issues, and then how do we engage? So taking the conversations that have started here a bit further and taking seriously, how does the health system and the health sector, how do we engage with politics, with power, with climate, with forced migration? Yeah.
You just said what I was going to say, so thank you.
Would you agree that you will involve the generals?
Maybe, yeah. Can we hear from this side and then go back?
Right. So my name is Sameh.
Thank you.
My name is Sameh. I'm from Yemen. I've been working in the field of humanitarian aid and health for the last 8 years, and currently studying at the University of Sheffield. And my research topic is on governance of health systems in transition. I've got a comment on the cholera outbreak in Yemen. Even though the cholera cases in Yemen were very massive, however, according to the last WHO statistics, it was more than 1 million cases of suspected cholera cases. However, everyone who was managed to reach the health facility was treated and was cured. And on top of that, the number of case fatality rates in Yemen, or the number of deaths as a result of cholera, remain very, very low, less than 0.2%, which means that the health system is still functioning, is still delivering the services, and it has to be supported. So my message to the WHO and all the donors is to continue supporting the system and not to bypass it, and to provide all the support that they can do to keep the system going on. So that's my message. Thank you.
Thank you. I'm kind of going left, right, yeah.
Hi, I'm David Bishai from the Johns Hopkins School of Public Health. I want to reflect on an angle on this inclusion that occurs to me. I went to some sessions by the Lancet Commission on Quality of Health Systems, and it was really important to contribute that the medical professions, nursing professions, hospitals have a quality problem. But I would submit that the lack of inclusion is a quality problem of the public health practice. That when there's a cholera outbreak that leaves groups behind, that was a failure of this profession. There are professionals that are supposed to be in every one of our communities whose job it is to keep us all included so that there should never be an outbreak. That's also public health malpractice. But the exclusion happens long before cholera shows up. And the work of being an effective public health professional starts years in advance of the outbreak. And when they are not being brought to the table, when they are not included in the planning and in the communication structures and the trust building and the surveillance, that is a quality of public health practice that was not included effectively in the work that the Lancet Commission did and really hasn't really reached our discussion here. There is a job, there is a person, a profession that is supposed to be doing the inclusion. We're not calling them to task. We are not assessing their quality.
Thank you. So I've got 3 minutes, and you guys have 2 minutes. So very quickly. Yeah, Naithun and then.
Yeah. I'm Naithun from Bragg School of Public Health from Bangladesh. It's not a question, just a comment I want to make from my own experience. We were doing a research where we were doing a review, and we are trying to identify who are the marginalized population in Bangladesh. So once we were done with the grouping, and then we found that we actually left no one behind. Everyone, almost everyone was included in the marginalized group, like from infant to children to adolescent to young adult, then elderly men and women, everyone was included. So what I felt like, if the system is not inclusive enough, then we all are at risk of being left behind, actually, at any point of our life.
Well, I think, yeah. I mean, there's also degrees of vulnerability, and there's some populations that are just invisible in systems and to people. Yes?
Hi, I'm Shanaz from Johannesburg, South Africa. And I wanted to pose to Sana, perhaps, to reflect a little bit on the framing and the positioning of the terms that we use. So you spoke about not just focusing on those that we left behind, but the forces that prop people up. So just reflecting on the words and terminology that we use and how that has a power in itself. Thank you.
Hi, my name is Anu. I'm from Delhi in India. I'm one of the media fellows. I've had the brilliant privilege of hanging out with the other media fellows this week, and I'm really glad, of course, that HSG did that. I just want to make a comment on the idea of accessibility, because it's, of course, related very closely with the idea of inclusion. So, in the health space, we talk very often about access to healthcare, access to medicines, and as a journalist and as a health reporter, I'm very interested in the idea of access to information, and I see that, in this room we have policymakers, we have academics, we have, technocratic people who are all involved in this idea of, information generating. And then we have people outside of this room on which policies are applied upon. And, in the sense, those policies can then either be inclusive or exclusive. But in the middle are people like me who are interested in access to information. And I just want to kind of encourage, academics here, policymakers here, to kind of view the media as, part of that process of inclusion. Because I think it's, yeah.
Thank you, Anu. We have to wrap up. I just wanted to say thank you so much for all of you staying till the end, dedicated group. I just want to thank you to the wonderful panelists. You guys have been great. I would encourage all of you to put forth your ideas for the next Health Systems Global Symposium. There's lots of issues we've been grappling with, lots of issues that have come up throughout the week. On a more positive note, there's a lot of committed people in this audience, also throughout this week, policymakers, researchers, activists, development practitioners, communities themselves. So I would just say, we need to keep at it. We need to be, be united, even with all the diverse opinions. I think it makes us richer. It enriches this community. And I hope, to see many of you in Dubai in 2019, yes?
2020.
2020. Oh, okay. So I've kind of accelerated the Health Systems Symposium, my excitement of being here. And thank you very much to the local organizing community, the committee and the consortium of UK institutions that brought this fantastic symposium together. Can we please thank them? Thank you very much. Do we go, Tolib?
Yes, you can go.
Okay.
Thank you very much.
Thank you.
Just
Thank
put your
you.
hands together for the wonderful, brilliant discussion. Excellent, insightful points, and thank you very much, the panelists, and of course the moderator. That was a really engaging. Okay, so this is the time where I have to welcome to this stage, not have to, but I would like to welcome to this stage and hand the proceedings over to the forthcoming chair of the Health Systems Global, Professor Asha George. Professor George's primary affiliation is at the School of Public Health at the University of Cape Town, where she is based since 2016 as the South African chair, South African Research Chair in Health Systems, Complexity and South Change. She's also an adjunct professor at the Department of International Health at Johns Hopkins School of Public Health. Asha, over to you. Please welcome to the stage.
Thank you very much, and it was a fantastic panel, and I want to thank all of you for staying behind as well. I know it's been a long week, but it's been an incredible week, and it's my honor to lead us through the closing phases of this gathering, where we'll be reading the statement, announcing several awards, the Poster Awards and the Media Fellow Awards, and acknowledging all those who have enabled us to come together here in Liverpool. The last few days have been a buzz of conversations and connections, sparking new inquiries and inspiring new endeavors. For some, this has been the first time to the symposium. For others, it's been a reunion of friends and colleagues that they've seen over several symposiums. But for all, it brings new inspiration, understanding, and commitment to strengthening health systems across our diverse contexts. Since its inception, the symposium has produced a final statement that seeks to summarize the nature of the discussions held, the learning shared, and the implications for action. Before I read it out, I would like to especially thank those who volunteered their time in supporting the drafting of the statement. I'd like to call out to Jill Olivier, Douglas Glandon, Anuj Kapilswamy, as well as Sarah Bennett and Lucy Gilson, who came in to help edit and bring down there's so much richness that has happened in the last few days, but to help us draft the statement and pull it all together. I'm also particularly indebted to the 62 rapporteurs and rapporteur leads that put in time in reporting back on the symposium sessions in real time, which is no small feat. So I'd like a round of applause for that. Everybody's busy talking, connecting, preparing their own presentations, and we really value the extra effort put in by those who reported back on the sessions. We'll be shortly posting the symposium statement on our website, and we seek your support in disseminating it, referencing it, and above all, in ensuring action on it. So here's the Liverpool statement for the 5th Global Symposium on Health Systems Research. This symposium commemorated anniversaries of 2 significant global health events, the Alma Ata Declaration and the birth of the UK National Health Service. These events have been foundational to the field of health policy and systems research, as they continue to remind us of the values that underpin our society, the need to keep pushing for goals to become reality, and how critical it is to combine socially relevant science with effective, accountable, and inclusive institutions on our path to the attainment of better health and equity. The symposium's theme, Health Systems for All in the SDG Era, encapsulates the spirit of these historical commitments and brings them forward into current debates and actions on the Sustainable Development Goals, and especially universal health coverage. Both the older declarations and the more modern goals are particularly relevant given the current challenges in our global context. Our democracies are under threat, our societies more polarized, our ecosystems undermined. Conflict and diseases such as Ebola, or as was discussed in the last session, cholera, continue without due political attention, and inequalities, including those related to gender and intersectionality, are increasing. In the face of such massive challenges, social solidarity, breaking down silos, smart use of scarce resources, and innovation are imperative. In Montreux in 2010, we committed to creating an international society for health systems research. 8 years later, this meeting in Liverpool has demonstrated how we have matured and gained confidence as a field and as a community. Each symposium shows improvement in our shared and continued commitment to diversity and inclusion. Liverpool welcomed 2,368 delegates from 146 countries, including health policy and systems, research scholars, practitioners, funders, policy actors, community activists, and the media. Together, we engaged in vibrant exchanges facilitated through 125 parallel sessions, including oral presentations, 451 posters, several launches, and thematic working group special sessions. Over half the attendees were from low and middle income settings and representative of all regions in the world. On social media, the hashtag HSR2018 had 6,204,009 users from the start of the symposium until 10 a.m. today, so I'm sure it's even more now, enabling those who did not have the privilege of being here in Liverpool to follow a part of the deliberations. Targeted programs and scholarship for policymakers, media fellows, emerging researchers, and change agents resulted in more perspectives and healthier dialogue. It was particularly satisfying to see the transition of those who were previously early career researchers mature into confident leaders of our community. So now to share some key reflections from the deliberations. Each of the symposium's 4 sub-themes, multi-sectoral action, community health systems, engaging the private sector, and leaving no one behind, help advance conversations and commitments to stronger and more resilient health systems so that the burden of such resilience does not rest on the most vulnerable, as was stressed in the last Health Systems Research Symposium. On multi-sectoral action, the multiple determinants of health and their interactions require us to span sectors outside of health. Just as people's lives and needs cannot be neatly divided into categories to match government structures and professional disciplines, our research, policy, and practice needs to transcend these boundaries. We need to be conscious that we predominantly represent the health sector and tend to view systems from this positionality. The importance of multi-sectoral action is acknowledged once again. Now we need to move beyond the rhetoric. On community health systems, engaging communities in policy, practice, and research was stressed throughout the symposium sessions, including the photo voice exhibit and the community corner. Moving beyond the importance of community health worker programs, we need to recognize the ways in which households and multiple actors in communities contribute to health to ensure truly people-centered health systems. On engaging the private sector, advances in commercial products, services, technologies, and business models have generated diverse forms of service provision, expanding the influence of the private sector. These advances have generated novel opportunities to expand the reach of the health system, as well as challenges due to the misalignment with commercial interests. Continued efforts are needed to move beyond polarizing ideological questions about whether the private sector has a role and towards more granular considerations within specific government, societal, and market contexts. Healthy critique about private sector engagement remains relevant and whole systems perspectives needed. The field is more inclusive on leaving no one behind. The field is more inclusive of marginalized voices than ever, but certain vulnerable populations remain underrepresented. While some communities benefit from improvements in quality, affordable health care, healthy environments, and economic opportunities, others remain marginalized without adequate access or voice. Yet movements have demonstrated that those in positions of power can be held to account. The assessment of power, privilege, and positionality remains central to our work. We also have several cross-cutting reflections that emerged, recognizing our systems thinking lens and the challenges that we must address in the future. First, we see silos and parallel conversations, dividing the terrain into sectors, disciplinary perspectives, and groups, between North and South, practitioners and researchers, technical versus relational approaches. We must continue to pursue robust debate about our conceptual starting points to promote greater mutual understanding. Further, as a community, we must nurture our brokers and bridge builders and be conscious of the intended and unintended effects across the entire health system and with other systems. We learned more on knowledge translation and embedded research experiences, but there is still work to be done on understanding local learning systems, which must include multiple stakeholders, such as frontline workers, the media, civil society, and the public at large. This entails building coalitions to advance implementation research and delivery science to address the challenges of equitable implementation, sustainable programs, and scale-up through wider use of research embedded in real-time policymaking, program management, and health service practice. In all of this, power is central to health policy and systems research. We have an activist agenda seeking to promote equity and speaking truth to power. We must make ethical practices routine in all our research activities, strengthen research governance, and support relevant training opportunities. We call for further research and action summarized in the statement and discussed in Liverpool. This includes broadening and expanding foreign and domestic investment in health policy and systems research, particularly for building capacity in low and middle income countries and opportunities for embedded research. Funding must align with national priorities, but also provide opportunities for broadening how research agendas are set in ways that are open to innovation and inclusive of marginalized voices. In conclusion, we affirm the importance of ensuring that all people are at the center of health systems, in the conversations and commitments to be made at the Global Conference on Primary Healthcare in Astana, and subsequently at the next 6th Global Health Systems Research Symposium in Dubai. One last one. I'd now like to move on to recognize, we're going to give out a series of awards. So first, the scientific committee knows that we were inundated with abstracts, and we're really pleased that the peer review process enabled the selection of 451 posters. I now have the pleasure of inviting Beth Hollyhead from the local organizing committee and Shea Abimbola from the BMJ Global Health to announce the poster award winners.
Hello, and thank you. This is an enormous room. Thank you very much for helping us to make this a vibrant and interesting poster competition. Thank you to all of our presenters, to our judges and volunteers. Our 3 daily winners are Disha Ali from USAID Maternal and Child Survival Program, Sherin Shaila Mahmood from ICDDRB, whose award will be collected today on her behalf by Dr. Kamrum Nahar, and also Deborah Thomas from Russia. Deborah has nominated her colleague Bandeth Ross from Cambodia to receive her award. And Bandeth, if you're here, please do come to the stage. This may be a surprise. So who do you have first? First, we have Disha, please. Thank you, Disha. And next, Dr. Kamrum, on behalf of Sherin Shaila Mahmood. And finally, Bandeth Ross, on behalf of Deborah Thomas, today's winning presenter. Oh, yes, of course. I'm sorry, can you return for us? We're going to have one photo with all of us together. Thanks, Disha. So leave the paper for us, please, just the award. Come.
So nice to see, you know, the posters enable more people's expertise and experience to be shared, and it's really nice to see the winners, and I appreciate all the effort going in reviewing all the posters as well. I now have, I'd like to talk about 2 new media initiatives that were started here at this symposium. You will have seen a new campaign launched this week called For Healthy Evidence. As the many sessions and conversations have demonstrated, evidence is a foundation of the strong health systems needed to achieve universal health coverage. It is only by using and applying this evidence can governments and other decision makers make informed choices and tackle the persistent inequities that prevent health for all. We're calling for everyone to ask and share their knowledge within and beyond the field. And thank you for all of those who went down to the HSG booth to participate in that campaign, and look forward to more tweets on this. Secondly, as you know, Health Systems Global serves not only to advance rigorous research, but also its application to policies and programs. In addition, HPSR can be challenging in a complex field to communicate and advocate for. We'd like to now introduce the inaugural HSG Media Fellowships Awards, which was one step to broadening our reach and strengthening engagement with journalists at country level and beyond. I'd like to invite Kabir Sheikh, as the chair of the jury of the Media Fellows Award, to introduce the award and the winner for the best feature article emerging from this fellowship.
Thank you, Aisha. As we all know, poor health is fueled by broader factors such as inequality and poverty, climate change, as has been brought up, and aging populations. And these complexities and these linkages can be quite challenging sometimes to communicate, especially for some of us academicians who are not very well versed in communicating messages effectively to the people who are actually in positions to make the changes. And for that reason, Health Systems Global recognized the vital role that the media play in presenting the bigger picture of these health challenges and the need to strengthen health systems to address them. And this is why 2018 is the inaugural year of the Health Systems Global Media Fellowship. We launched this program 2 years ago, and we had over 200 applications from professional journalists, out of whom 6 outstanding journalists were selected. And 5 of them have been able to come here to the symposium, and I can see all of them sitting over there, so I'd just like all of them to give us a wave. So our media fellows are Anu Bhoyan of The Wire, India, Patience Nyangove of Confidente newspaper, Namibia, Vanessa Adie Ofyong of Media Trust Limited, Nigeria, who was unable to make it, Irene Rodriguez Salas of La Nación newspaper, Costa Rica, Daria Sarkisian of Medusa.io from Russia, and Obontika Ghosh of the Indian Express in India. Many of you will have seen them throughout the week, and we'd like to extend our congratulations to all of them for their stellar contribution to our conversations here at the symposium and also through their own media platforms. All of them wrote feature pieces leading up to the symposium on a range of issues, ranging from the challenges and pitfalls of elderly care in Russia, to a comparison of cholera to Boko Haram in Nigeria, to the coverage of India's new health scheme. And in case you haven't read them, please do look them up. They're all linked on the symposium website. We had a very distinguished panel of judges to review these pieces, and the judges included Darren Dodd of the Financial Times, Jenny Lee Ravello of Devex, and our guest Akaki Zoidze of the Government of Georgia, and a leader of our thematic working group, Daniela Rodriguez, and myself. We reviewed the pieces into an extremely difficult decision. They were all excellent pieces touching on important issues and critically touching on some of the challenges that we've been talking about in this last week. However, the winning piece demonstrated a clear need for health policy and systems analysis and was captivating to read and engaging. The piece weaved a human story into a narrative around integrating indigenous people's experiences and beliefs into their care, and the author articulated the need to work and involve communities in their health and the systems that support them, and crafted a powerful message of how this can change health systems for the better. I will invite the board chair, Professor Asher George, to give the winner of the inaugural Media Fellows Prize to Irene Rodriguez, writing for La Nación in Costa Rica.
really fabulous, such a delight to see. And now we're going to give thanks to two key committees who really shaped the character of this symposium during the 2 years of preparation and hard work that went into prior to the symposium. The first is the Local Organizing Committee, drawn from the UK consortium that won the bid for this symposium, who not only brought us to this conference hall, but brought us to the city of Liverpool. The opening ceremony gave us a taste of their past and present, acknowledging the historical debts they owed and the contemporary diverse communities they embody. The public health walk, community corner, and the social night at the stunning cathedral enabled us all to get a further understanding of the rich textures that make up the ground realities of Liverpool. In addition, we're going to take the opportunity to recognize and thank the Program Working Group Committee. They're the ones who took all your suggestions for conference theme and crafted the call of abstracts that generated such a massive response. They worked with the scientific committee to peer review the many submissions and to weave so many contributions into a robust program, one that was provocative and inclusive. Let me invite the HSG Vice Chair, Barbara McPake, to give our token of appreciations, and please give a huge round of applause to Sally Theobald and Tim Martineau as representatives of the Local Organizing Committee, as well as to Kara Hansen and Kumanan Razanathan as representatives of the Program Working Group. Please come forward. Thank you so much. Fabulous. Are you going to do photos separately? Thank you. Oh, Sally. As many of you know, our next symposium will move to the Eastern Mediterranean region as a means to strengthen the health policy and systems research community across the region. While many countries in the region experience conflict and human suffering, it is also a region historically known for trade, migration, and the exchange of ideas. We're delighted that our next symposium is hosted by a partnership co-led by the United Arab Emirates, bin Rashid School of Government, and the American University of Beirut in Lebanon. I kindly invite Tim Martineau, who's right here with me, as the representative of our Liverpool host, to hand over the host key to His Excellency, Dr. Ali Sabah Al-Mari, Executive President of the Mohammed bin Rashid School of Government from Dubai, UAE. This is a key tradition that we started in Vancouver, and after the passing on the key, His Excellency will share a few words with us. Thank you. Here's the key. Here's the key.
Dear member of the Health System Global, on behalf of Mohammed bin Rashid School of Government in Dubai, United Arab Emirates, we are delighted to host the 6th Global Symposium of Health System Research 2020 in the Eastern Mediterranean region in partnership with the Knowledge to Policy Center at the American University of Beirut in Lebanon. I would like to extend the invitations to all health scholars, policymakers, academics, private sectors, and practitioners for the next HSR 2020 Symposium. Since Mohammed bin Rashid School of Government establishment in 2005, under the patronage of His Excellency, of His Highness Sheikh Mohammed bin Rashid Al Maktoum, the UAE Vice President, Prime Minister, and the ruler of Dubai, the school has proven its importance as a unique role model for academic institutions, supporting good governance in United Arab Emirates and across the Arab region, and building future leaders through an integrated system offering educations and training program as well as research studies. The school also organizes international and regional conferences to facilitate and exchange the knowledge and ideas in the field of public administrations and public policy, including health policy and search system. Today, we are proud of the close relationship and cooperation with the Health System Global and the Knowledge to Policy at American University in Beirut to support the efforts in health system research and providing a valuable platforms for knowledge exchange and policy dialogues. We are encouraging all of you to join us in next symposium and visiting Dubai, which is considered to be one of the fastest growing cities in the world, a modern business hub with its diversity populations and cultural activities. At the same period of the conference, Dubai will be hosting a global events, Expo 2020, which will be adding another value to your visit. At the end, I have a message from the organizer. I have a message for the organizer to invite all of you to share your ideas for the themes of the HSR 2020 via social media applications of the conference, or by contacting HSG via email before the end of October 2018. Wish you all the best and see you in Dubai, inshallah. Thank you.
The Eastern Mediterranean region, a historic region that served as the backdrop of legendary myths, witnessed fierce battles, and demonstrated boundless resilience. The Eastern Mediterranean region had a remarkable influence on medicine, public health, and science as we know them today. The first modern hospital with wards and teaching centers were created, where all patients received free health care. Al-Zahrawi invented many of the surgical instruments still in use today. One of the first and most influential medical encyclopedia, the Canon of Medicine, was written by Ibn Sina. The region contributed to the proper diagnosis of diseases such as smallpox and measles, discovered the contagious nature of tuberculosis, and wrote one of the oldest Arabic compendiums of medicine on pediatrics and child development, while Baghdad established the first pharmacy in the world. Scientific discoveries were also an EMR heritage, from developing modern algebra by Al-Khwarizmi to discovering the law of refraction by Ibn al-Haytham and creating the world's first university by 2 women in Morocco. Today, non-communicable diseases account for 75% of the burden of diseases in most countries of the Eastern Mediterranean region, with cardiovascular diseases, cancer, diabetes, and chronic respiratory diseases as the largest contributors to mortality. When it comes to the NCD-related risk factors, the region bears some of the highest rates. The NCD epidemic is aggravated by inadequate control of the commercial determinants of NCDs. Environmentally, did you know that the region is the most water-scarce region in the world, with 60% of the population living in areas of high or very high water stress? The new realities confronting the region and the world have been amplified by ongoing wars, internal conflicts, and massive population displacements. Numbers show that out of a total of 68.5 million refugees and internally displaced population worldwide, more than 57% of them came from the region. 4 countries in the EMR alone host more than half of the world refugees. The challenges and complexities facing the region today require an expansion from primary focus on health to a broader focus on the SDGs and multi-sectoral actions. In this new global context, strengthening the science, policy, society interface and ensuring the continuity of science policy dialogue is critical for all countries at all levels. Health Systems Global will be bringing the 6th Global Symposium on Health Systems Research for the first time to the Eastern Mediterranean region. The winning bid was put forward by the Mohammed bin Rashid School of Government, Dubai, in partnership with the United Arab Emirates and in coordination and close collaboration with the American University of Beirut through its Knowledge to Policy Center at the Faculty of Health Sciences in Lebanon.
We are delighted to host the 6th Global Symposium in a region where advancing health systems is key on the agenda. We also need to accelerate our contributions to the Sustainable Development Goals. The close collaboration between the Mohammed bin Rashid School of Government and the American University of Beirut through its Knowledge to Policy Center in Lebanon culminated in this much anticipated event.
In preparation for the Health System Research Symposium 2020, we take the opportunity today to initiate global and regional consultations to help shape the 2020 program. We invite you to contribute your thoughts, ideas, and suggestions as we prepare for yet another successful global symposium. HSR 2020 will provide a platform for strategic partnerships, build bridges across intellectually diverse regions, and unleash the collective capacity to strengthen health systems and development.
We look forward to welcoming thought leaders, policymakers, researchers, students, practitioners, all stakeholders from around the world in Dubai to discuss and exchange ideas about advancing health systems in our global dynamic city. Ahlan bikum fi Dubai.
As we leave Liverpool more energized, we look forward to continue the journey with all of you and to welcome you for the first time in our Eastern Mediterranean region. In an era of post-truth politics and alternative facts, we stand by those who champion evidence, science and reason, and we trust you will do the same. أهلا وسهلا فيكم بالشرق الأوسط.
أهلا وسهلا فيكم في الشرق الأوسط.
I really appreciate that film, and I think it gives you the reasoning behind our selection, and I'm really going to look forward to the broadening participation. It is the region where we have currently the least participation in our symposium in the abstracts, and I'm really looking forward to learning a lot there. So now we come to the final part of the symposium deliberations. It comes to our time to give our final vote of thanks. This symposium is the result of diverse groups of people who have been working behind the scenes for the past 2 years. It's not a small endeavor, and we're grateful for the commitment of many key stakeholders following through on multiple responsibilities. There are many people to thank, so if I could ask you to hold your applause until the very end, despite your enthusiasm at this very late hour. So let me first start by thanking the 285 members of our scientific committee, without whom the peer review process that shapes the program would not have been possible. In addition to our debt, we have a deep debt to the whole of the program working group committee members, and we're also grateful for the support provided to them from Sarah Brown. We are also grateful to the Emerging Voices Secretariat for hosting another cohort of EVs prior to the symposium, bringing added energy and engagement to the symposium proceedings. We also thank the members of the local organizing committee for organizing and judging posters and awarding the prize winners under the leadership of Beth Holyheed. We're grateful to the satellite session organizers, John Warner, and from the Alliance, and Gary Aslan from TDR for helping organizing the skill building sessions. There's also special thanks to the logistics committee members, and especially to Maria Phillips, who has worked hard with PCO and ACC Liverpool team and other colleagues to assure smooth implementation of the symposium. Well, we have a lot, we have 10 more thanks. So we're thankful to the City of Liverpool for their support and welcoming us here to the city. We thank the Communications Committee members for their hard work before and during the symposium. Special thanks goes to the Fundraising Committee for their tireless follow-up and ensuring support for the symposium. The Executive Committee for coordination and oversight of the efforts of all the other symposium subcommittees and taking key decisions that mattered for the success of the symposium. HSG's foremost and continuous partner, the Alliance for Health Policy and Systems Research, deserves special mention for their integral contributions to the symposium. We'd like to give a special thanks to Abdul Ghaffar for being a guiding light in key symposia committees, catalyzing fundraising, supporting the policymakers track, nurturing the EV program, amongst other contributions. We're grateful to our co-sponsors, the World Health Organization, particularly the European Regional Office for their crucial role in organizing efforts. We're thankful to our funders, without whom we would not have been able to organize the symposium, and importantly, to ensure close to 280 scholarships to bring participants from all over the world, but particularly from low and middle income country settings and students from high income settings. We would not be here also without the foundational support of the Secretariat staff in Brighton and Tbilisi, particularly George Godsadze, Tom Barker, and Nanuka Jalagonia, whose tireless efforts orchestrate all the many layers and details that must fall into place. We thank also the HSG board members for their leadership of the Society. We're deeply grateful to all the volunteers and many others who have worked behind the scenes and in the conference venues. And most importantly, we're also indebted to all of you and the membership for submitting all your abstracts, screening them, presenting them, being here until this very last day, discussing, debating, and affirming the many contributions that keep us learning from research to strengthen health systems as a key pillar for the within the Sustainable Development Goals. So a huge round of applause and a standing ovation. Thank you so much. We bid you farewell, safe journey, and we look forward to seeing you in Dubai.